Sweet. Okay. Thank you, Mike and Steve, for doing this. This is like a kind of a unique format because it may primarily be an initial discussion between the two of y'all, and then I want to open up to everyone kind of closer to the end or maybe midway through. But could we give just a short little background on both y'all? And then Steve, what were you in charge of within the paper, and what was your kind of responsibilities? And then maybe Mike, we can go into your initial set of questions.
Sure. Sounds good.
Steve, do you want to go first?
Sure. So do you want me to, did you say introduce myself or just my role with the paper?
Yeah, you can do both.
Okay. Hi, good morning, approaching afternoon, which reminds me I need to do my football picks right after this. My name is Steve George. I do work at Duke University, clinically trained as a physical therapist. Have been doing research in musculoskeletal pain. I guess, I went to Florida in 2002 to do my postdoc. So I guess I've been doing that more or less as an emphasis now, approaching 20 years, which is really, really scary. But I did start clinically and I've done some work across different patient populations, a lot of back pain, some shoulder pain. Generally, I view musculoskeletal pain as kind of, more things in common than different. So I try not to get too hung up on the region, but some people still do. So I think, low back and shoulder is where most of our data has been generated. The clinical practice guidelines, it's a little bit of a long and sorted tale. The original clinical practice guidelines were published in 2012. I was involved in those, more of a supporting author role. And the original plan was to update those every 5 years. For those of you keeping track at home, 2012 to 2021 exceeds 5 years. So there was a plan and a team was put together, and I was on that team, not in a leadership role, but as a supporting author. You can look on the website if you want to know who the original people were, but I'm not going to mention any names. But there was just some difficulty in getting the group together. I have some theories on that. I don't know if I want to share them here, but it was a busy group. It wasn't anything to do with people not getting along. It's just a busy group, and there was a lot of opportunities to do large-scale clinical trials in back pain, and it just so happened some of those people in the group were involved with those. So for whatever reason, the update that was supposedly due in 2017 and 18 didn't happen. The Academy asked Julie and I to reconvene, and if we would stay involved and move into more of a leadership role. We thought long and hard about that because we knew what the time commitment was. So then we basically started up with version 2 of this in late 2018, 2019, and we at that point obviously had to redo a search. Some of the people that were involved, were replaced, and we ended up with the structure that we went with, which is essentially having 4 working groups, and each of them were to kind of look at their body of literature, compare what they found with the existing recommendations. We did find it difficult to maintain continuity across all the recommendations, which I'm sure has been noticed. I think some of the things that were reinforced in the original guideline, such as the use of the ICF language, were hard to bring forward because, frankly, most researchers aren't following the ICF model. Some of the subgrouping is really difficult based on inclusion and exclusion criteria. So we had some discussions of whether we, wanted to try to make our best guesses on some of these things or just kind of put it out like it was. And we decided, it probably wasn't in our best interest to try to make assumptions about what ICF groups or what, were based on, the inclusion criteria. So if people were very explicit, we were able to get into some broad subgrouping categories, but we definitely weren't able to get into some of the things that, PTs and chiropractors and others who treat back pain really enjoy talking about, like mobility deficits and movement coordination, and that I think is a reflection of inclusion exclusion criteria more than our ability as a team. So we tried to carry forward, from 2012, but the connection was difficult. As has already been brought up, we were not charged with doing a meta-analysis. It was more of a systematic review, and it was meant more to look at what the current recommendations were and see what they were to be updated. And then the last thing, because I'm sure there's, people want to discuss this and not just hear me go on and on and on. This is very therapeutic though, Chris, thanks. I haven't had a chance to, to unload like this. The last thing is we just decided to focus on interventions. The prior guideline was quite broad, which I think for the first guideline was okay, but we felt like to redo searches across intervention and diagnosis and outcome assessment, we were already way behind the 8 ball in updating this, and we wanted to focus in one area. And with the emphasis on non-pharma, we decided to focus on interventions, because a lot of guidelines recommend non-pharmacologic, but they don't give you much more guidance beyond that. So we thought one way we could differentiate that was to try to make more granular recommendations on specific non-pharma approaches, at least those that are commonly used and reported in the literatures by PTs. So that's the long and the long, not long and the short, the long and the long of the background of my involvement. So I basically see myself as a team leader on this. It was a team effort. Frankly, Julie and I talked about who should lead author, and we just, we decided that since the search was done at Duke and I was being more involved with kind of the overall leadership, that was probably more appropriate. But how some journals now are letting you say, equal contributions. This one, would be pretty close to having equal contributions across many of, especially the 4 author leads, and then Julie and I would have equal contributions, and Catherine too. So that is that.
Perfect, thank you. And then Mike, maybe a brief intro, and then we can just roll straight into some of the questions you have.
Steve, that sounded cathartic. I don't know that 11 a.m. is too early to start drinking. I mean, this may make for an interesting discussion.
Yeah, well, after the Steeler game Thursday and that, I feel much better now. So
there you go. Sure. I'm a visiting assistant professor at the Health and Human Sciences Department at Bridgewater College here in Virginia. I'm also a new researcher specific to musculoskeletal pain, currently looking into low back pain from a mixed methodology standpoint, as well as some other stuff specific to persistent pain populations engagement of physical activity in the United States. Those are kind of my main things right now, and then a small kind of hand in activism as it relates to philosophical approaches to persistent pain. And then I teach, unlike Steve, I am getting buried currently at the end of the semester with final grades due tomorrow morning at 8 a.m. So as soon as I get off of this call today, I will be attempting to submit grades for students. And I work with barbell medicine, pain and rehab clinician. That's how I know Steve, is through Derek Miles, who is currently a new dad. I don't know if you heard about that.
That's awesome. I was going to ask. So Derek, that's great. Send along my kudos and congratulations.
I will. I definitely will. They should leave the hospital today, actually. I was just talking to him last night. So everyone's okay. Kim's doing well. Beautiful baby girl. So happy for them. And then
that seems appropriate for Derek too, to have a baby girl, I think, for those.
Oh, well. I had my little girl, Lucy's 2.5. And so then he told me he was having a little girl, and my wife's named Erica, and we were both like, we kind of are interested to see how this plays out. So yes. And then I owned a clinic, but I feel weird even saying it because my clinic's kind of just sitting in Harrisonburg. I'm not really using it. When I got picked up to teach and do research full time at Bridgewater, I kind of backed way off of in person. So I mostly just do remote coaching on the side now, in addition to teaching and research. So yeah.
Awesome. Well, the reason I guess I wanted to ask both of y'all was because obviously Steve's the primary author, and then Mike, has done a lot of or has been very interested in low back pain and talks about it frequently. And then he started a Twitter thread of some of his thoughts on this CPG. So I thought it'd be good to have both of y'all, talking this through. And Mike sent me this morning a kind of a list of some questions to ask Steve, maybe to hit it off. And then if we kind of run through those, I can open it up to the group, or I have some questions as well. Does that work?
Yeah, that sounds good. Steve, I thought it might be useful just to kind of give, in your own words, a broad overview of the purpose of clinical practice guidelines.
Yeah, I mean, it's a really good, really good question. I definitely, we did a journal club for our Duke MSK, and I actually went and looked and found Wikipedia, I thought actually did a pretty nice job summarizing, the intent, and they are meant to be guidelines. I view them as kind of general. They're definitely, I don't view them as prescriptive. I don't view them as, something that people have to do. That's why some of the language of the recommendations, is challenging, because they the framework we use, there was a little bit of putting us in a box of limited words that we could use. So, I view them essentially as a way to quickly get an idea of, what the evidence base may be for a given intervention. I think it's even better if you can get an idea of a little bit about the patient populations for which that evidence base is based upon. Meaning more, a little more nuanced than just back pain. So I kind of view them in that way, a general, not prescriptive, almost like a scoreboard of the evidence base for a given intervention. I think the challenge, as everyone on this knows, is how applicable to that is to like an individual patient, and I mean, I can't answer that directly. I think some of that is actually out of scope with guidelines. But, I view it more in that kind of, general approach. So in other words, if we recommend something, it doesn't mean, everyone has to use it. It just means that you might want to consider it before some other things, but there's obviously lots of reasons why you may not want to be using something that is supported by the evidence. I think if you start doing that too much, though, that's where it helps, is it gives you an awareness of what your overall practice patterns are. But for an individual, patient encounter, it can be a little bit tricky. I kind of view it like, your batting average would be how much you use, and your batting average should reflect what the current evidence base is. But any individual at bat, someone can be made to look really bad or really good in any one individual at bat. But that's not really what the evidence is for that person or that intervention. Does that make sense at all?
Yeah, it definitely does. I often look at them as like just an extension of evidence-based medicine. So like, how do we take the totality of data on this particular topic and get it to frontline clinicians to make informed decisions with their patients collaboratively? Is that an accurate summation, you think?
Yeah, I think so.
Okay. Can you talk about, and you've already somewhat touched on this, but kind of the process that goes into creating clinical practice guidelines? Because I know you were part of the 2012 and then 2021. Were you on other CPGs or?
For the academy?
Yeah.
The ortho, I think I've pretty much stuck to the low back. I have been involved with other practice guidelines. I'm currently involved one with the American Psychological Association for chronic musculoskeletal pain. So, I've been involved with others outside of PT, but I think those are the main ones I've been involved with PT.
So what's the process look like? Just broad overview. It doesn't necessarily have to be specific to the current one we're talking about.
Yeah, I think obviously a key element is having research questions that will inform a literature search. Ideally, the literature search is done by someone with expertise in the search. One of the things that I think is semi-strong about our is we had a librarian perform the literature search. We didn't mess around. We obviously helped develop the search terms, but we were given the search results. We weren't the ones actually doing the searching. So, if you can have that some separation between the search and the authors, I think that is helpful. But, we're talking about common themes. So a systematic search is one of them. And then there's a compilation of the evidence, and then there's an assessment, and then recommendations. And I think that's where you can start to see different, branching approaches to, we did not take a quantitative approach to synthesizing the evidence. Ours were linked to prior recommendations, and we were seeing, if there were some studies that essentially moved the needle enough to change those recommendations. And
Okay.
not all guidelines will, have prior recommendations that they're looking to support. I think most of them kind of start anew, and they just kind of give you an idea of what the overall support is for a given body of interest. And I think the other thing is a lot of recent guidelines do encompass more of, go from diagnosis to intervention. So that's the other thing, but that's really driven by the research questions or the questions up front.
So you guys were more or less, as you said, looking at non-pharmacological interventions that are available to rehab professionals, and then comparing that to 2012 guideline data, seeing are there updates along the way that we need to change our recommendations.
Yeah, and I think, some decisions that we made early on that people have questioned and justifiably so, is we did decide to limit as an inclusion criteria studies that were primarily performed by PTs or in a PT setting. A lot of this was just based on, and we did all this before, looking at the search results or anything. A lot of this was based on the acknowledgement of there are lots of high level practice guidelines out on back pain. So we were thinking of ways to differentiate ours slightly. And two, the evidence base is so large for back pain. Are there justifiable ways, that we can limit that and still get to decent recommendations?
What was the decision behind restricting to PT directed interventions? Because I know like Mike Schneider's an author on that as well. Was it just because it was in JOSPT or?
Well, first I'll say that was a decision made by the author team. It had nothing to do with JOSPT. JOSPT has, other than requesting certain tweets be deleted, JOSPT has not been very much involved in this, which is a good thing. I mean, They give us some editorial guidance. We need to fit how they want to disseminate it. So, some of the way the recommendations are worded and things but as far as the question or the search, they were very hands off. So that was a decision, made by the author team. And I really think for me, it was a differentiation aspect that I talked about. Like, we have some people on there that are quite accomplished low back pain researchers. And we did have a little bit of existential angst of why are we doing another clinical practice guideline when there are some really good ones out there. So I think maybe we overcorrected, maybe it was like, what was the one Star Wars that everyone hated? The Last Jedi, the eighth one, maybe we tried too hard to be different. Yeah. And that was not a good choice at the beginning. I think the other thing that really helped push, us is specificity. I mean, there's some specificity to these guidelines that if you don't like the recommendations, I get it. But if you can't deny that what we did is the evidence based on PT driven research. So one of the things that we thought would really piss people off that didn't as much, and Geronimo's already told us why, but because he thinks we got this one closer to being right, was the exercise one. The exercise, but our read on that is PTs haven't been as active in exercise trials as some other people have been. So some of the kind of, more well-known exercise studies for back pain weren't included. And the ones that PTs do, if Cherie Silfies was on here, she led the exercise group, she would tell you how bad our exercise trials are. Yeah. She was really disgusted with them. So, to me, yeah, that's something that we were able to tease out by limiting the PT, where you say we're supposed to be good at exercise prescription, but when you look at our randomized trials in back pain, you wouldn't get that. You would not
Yeah.
get that from looking at the trials. So, there was that specificity and differentiation elements that I think drove that. And Mike, yeah, Mike was on there. I mean, when you talk about other things, I think the academy can do better. It would be nice actually to have broader multidisciplinary representation. The other existential angst we have is, we're PTs assessing the PT literatures, making recommendations for PTs. That's a challenging, thing that's a tightrope, because there's a lot of room for bias. There's a lot of room for, and things we're not even aware of. It would be nice to have some other multidisciplinary involvement. So, the one I'm on for the American Psychological Association, I'm on there because I'm, the PT representation. So sorry, that was a little bit of a wandering response.
Oh, no, you're good. Yeah, that's helpful to hear insights to it. What was
Mike probably would tell you, by the way, I don't know if you know Mike Schneider, I don't know that he totally agreed with it, but he understood the rationale, and,
Sure.
he was not happy. I mean, but he was willing to put his name on this guideline, and he was involved with some other guidelines that he was so frustrated with, he stepped off the committee. So I wouldn't say it was contentious. I think it was, he noticed it probably the most in the manual therapy literature. So he was a little bit more vocal about it.
And can you elaborate on that? In what way?
He thought there were several studies that were potentially relevant that we excluded because they weren't, delivered by a PT or studied in a physical therapy setting for manual therapy.
Were those specific to showing a positive effect or negative effect or neutral?
I wish we had the time to go back and look at that. That would be a really good exercise. But, the body of literature was so large as it was, that we couldn't go back and see, what the effect was of some of our decisions. It would be cool to do that with exercise and manual therapy. I think that would be really cool. I think Mike anecdotally noted too, with dry needling, there would have been many more studies with dry needling in the guideline, but I don't know if they were negative or positive studies. It's a great question.
I'm pulling up the guidelines now, but the recommendation for manual therapy, and specific to just like thrust versus non-thrust, being a should do recommendation, what was the driving force behind that decision making? Do you feel as though the evidence is kind of a two-pronged question? Do you feel like the evidence supported that recommendation?
I think, the prior recommendation taken into consideration, the evidence suggested that we should not drastically change the current recommendation. So that was one of it. And B, the challenging thing with manual therapy and exercise, well, actually all of them, is having to make these recommendations in a vacuum, with very little knowledge about comparators and the size of the effects. I think, my read on the manual therapy literature is, depending on what you compare it to, there's a good chance that there's a small short-term benefit of manual therapy. Now, we've talked about this afterwards. Maybe there needs to be levels of what those comparators are. In revisionist history, maybe we would create something where, manual therapy, what would the recommendation be, as a frontline treatment compared to something like an opioid, or doing nothing, or doing, usual care. There's a couple of different levels, which I think some of them would be, stronger than others. But, the game we were playing, the structure we were playing in, we had to make an overall recommendation. It had to be based on the prior recommendation, and that was the kind of the starting of the equation. And then we did not see evidence of studies that suggest we should drastically downgrade manual therapy. Now there's lots of legitimate questions, and Geronimo's on here, he can, if he wants to, there's lots of, I think, really good questions about should we have taken into account the size of the effects better, and things like that, and what the comparator was. And that, I think that's all completely, on the table for discussion. The other thing is, for people on this should know, Mike made the original, and I'm not throwing, this is our process. Everyone stands behind everything, by the way. We've already had this discussion.
Sure.
That we're, Mike made the original recommendations. The rest of the team looked at them. Manual therapy was not one we changed much at all. There were some exercise, there were some we had a lot. Maybe we should have had more discussion about manual therapy, but manual therapy we did not. And it, so it moved on. Basically, Julie and I looked at them, the team looked at them, then Julie and I looked at them, and then external reviewers looked at them. So there were multiple people looking at these along the line. It wasn't like, we landed on there and then passed it off.
Yeah, I definitely think, like, to me, reading these and going through these for the past couple of weeks, it almost felt as though the quality wasn't necessarily assessed. Like you say, the group says multiple times throughout the guidelines, when you're talking about gap in knowledge, we need more level 1 RCTs. I mean, that's pretty much on repeat throughout the clinical practice guidelines for almost all recommended interventions. And so I would pull some of them that were discussed as being like high quality. For example, I'll give Fritz et al., which is citation 57, thrust versus non-thrust joint mobilization, which was an RCT in 220 patients. But when I go through that, is there a small statistical effect between usual care versus thrust? Sure, but it's quite small and debatably, clinically meaningful at all. And even so, like from a non-pharmacological standpoint, a third of both groups were on opioids. So I'm trying to make sense of, like, what does this mean for the clinician? Because these recommendations are coming off of randomized control trials like that aren't very high quality, in my opinion, but are giving grade A recommendations that folks should be doing this. So I'm trying to square these two. Does that make sense?
Yeah, and I think, manual therapy is a good one, because if you look at other guidelines, they're as low as C, the recommendations from. So I think, there's some volatility in that market, and we traced, I think, the majority of our volatility in that recommendation is driven by what the prior recommendation was, and I think the other part is, not looking at the size of the effect as much. There was only one study, so I think, and again, I wasn't involved in the nitty gritty of this particular one, but I'm thinking, a small effect, if the prior recommendation is A, that it was an effect in the right direction, there's not enough there to suggest it goes, in the other direction. If we were starting anew, maybe it would be graded differently, and maybe that's what we need to do with the next generation of these, which hopefully won't take 10 years and definitely won't involve me. So, I think people can have some freedom.
Yeah.
I would like to think, there is enough resources to do this maybe in a quantitative way, or, use a meta analysis, so that we, instead of, talking about, well, this is how we interpret it, and this is, we can have like a common, and I know that's not, you can do that now. It really is, to me, was a question of resource and expertise on the team. These are, I'll get a little bit remiss here, but these are, I think, potentially the last iteration of these guidelines being kind of grassroots efforts. I think if our academy and our profession are serious about these, they might have to take a slightly different tact than having people, do this kind of in a grassroots volunteer approach, because the bar has really been raised, on what expectations are for how you synthesize and pool data and things like that. And other groups have been able to keep up with that. Because I know there was some question in social media about, the funding and all that. This is essentially a service project, for the people on there. There was no funding to me or our institutions. We got a small grant, which we tried to funnel mainly towards Catherine Norman because she ended up being the coordinator and she's a PhD student. So we wanted to pay a little bit of her time, or at least get her to CSM, for the time that she put in. But no one drew solid. And I'm not using this as an excuse, by the way. I'm just kind of being transparent about the process.
No, I don't receive that as being an excuse at all. I mean, it's like being a peer reviewer, right? Like it's the goodness of your heart, supposedly. So,
right.
Yeah.
So I think, and in a perfect world, we would have handed off our search to some non-PTs and they would have done something in parallel. And then I think we would have come to a consensus. Like we would have had our PT recommendations, another group would have, but that, I mean, when you look at the size of the literature, that would have been a huge ask for someone.
Sure.
I mean, you'd have to fund people to do that. You'd have to have some funding to do that. So, and coincidentally, and it's kind of like, it's even a bit of irony. Chad Cook at Duke has just received some funding from that he's going to start a center to look at manual therapy evidence. And one of the goals is to have like a living systematic review and meta-analysis. So like I said, I think some of these things are going to there's going to be a lot more data sources moving forward.
So it sounds as though, just to kind of summarize, is you guys were hampered a bit because of your starting point being based on 2012. What would it have taken to downgrade prior recommendations, do you think?
Well, I think it would have taken a trial, to suggest that the usual care was better than, something that was more manual therapy driven. I'm not as concerned about I understand your point about the opioids, but in a parallel group design, remember some of that stuff's going to cancel out. So hopefully
Sure.
we're getting the effects. So I think it would have taken some of the trials, pushing a little bit harder in the other direction. I think, there's a whole host of smaller manual therapy trials that it's either comparable to or slightly better. I don't know what to do with those because if the original recommendation is favorable, they don't push it really one way or the other. And maybe for some people, though, that's an indication that there's not any evidence, and that kind of drifts it towards, there's no clear definition of superiority. And I don't know, the way I interpret it is A and B doesn't mean it's clearly superior. It just means it's an option. It's an option on the table.
Okay.
Because if we had superiority, clear superiority, the guidelines would be very short. There would not be much at all going on.
Well, what's interesting is like the very beginning, if I recall correctly, you guys even state like there wasn't evidence of superiority between interventions, but then we have the grading. So I'm like, well, this is interesting. It seems a little mixed messaging, so to speak, because my bias, like looking at totality of evidence, even if we were to layer in other options that aren't available to rehab professionals, right? Like all things being equal, we can gain effects all sorts of ways, which so it's like, it's tough for me to make sense as a clinician, but also as a researcher of like, how do we have such poor evidence, but grade A recommendations? And then when we look at the totality of evidence of all available interventions across the board in healthcare, specific to low back pain, we're overall fairly small effects anyways. So why should we be going by these guideline recommendations comparatively to something else? That may not be the greatest question. Does that make sense what I'm asking?
Yeah, no, I mean, this is where I've been starting to run my head into the wall. And I think the next generation of clinical practice guidelines shouldn't do any of this stuff. I think they should be about synthesizing who responds to what. And in that evidence, there's nothing out there, but because I think what we have distilled and we argue much more over how to make the recommendation than like what you said. Most of the effects are small, and a lot of times the size of the effect is more dependent on the comparator, I think, than the actual treatment. So what would really help clinicians is is there any guidance on who might do better with manual therapy compared to exercise versus what RCTs, which are really designed, what's the average effect of manual therapy? And, I talked with the APA group, and they all thought it was a great idea, but said, we can't do it. And we talked about it in the academy, and it was kind of the same thing. I think there's some hesitation to get away from this bread and butter. Let's only look at RCTs and let's try to make decisions based on pooled, average effects from studies. So I don't disagree with you, but until someone is willing to really, challenge that a little bit, I think we're going to be in this realm where people are sorting, small effect sizes, and there's going to be disagreement on whether that's a grade A level or grade B level. Clearly, our group interpreted this more with, that was the context that you just said, that there's no clear superiority, but this is what we would recommend. And maybe we were thinking a little too much about what are all the options? What are all the options, not just, the non-pharma, because I don't know how useful it is to my physician colleagues when they hear everything is kind of the same. And I know part of that is the truth, but if there are some slivers of hope, I don't know, I think that's where the language and not knowing, manual therapy compared to what, to me, is the really big question. Right? If we have an option of receiving an opioid, doing nothing, or receiving manual therapy as their first treatment, I know what my bias is.
Sure. But there are several, one in particular comes to mind, reviews showing equality in effects, right? And so it's just, is there any concern? Because I've read, your prior papers over the years, is specific to this topic as well as it relates to manual therapy. And I know this isn't related to clinical practice guidelines, but I'm generally curious on your viewpoint of this. Are there any concerns, and what needs to be said to rationalize these recommended interventions to patients? Obviously CPGs can't talk about this, but at some point, if a clinician's like, yes, I should do thrust versus or non-thrust or exercise or whatever, you're having to give informed consent. So you're having to rationalize the intervention to the patient. Is there any concern there? And what needs to be said to get buy-in to do the intervention, to get that small effect we're looking for?
Well, if I'm understanding you correctly, I think, in the clinical setting, I think very rarely is there equipoise about what the treatment effects are. It reminds me of my postdoc advisor, who was a clinical psychologist, who, he said, I used to get great results with EMG biofeedback until I read the literature and then gave the patients the real deal about EMG biofeedback, and then it became less and less effective. So I kind of waver on this versus, do we say, here's two treatments that I think you would potentially benefit for. Do you have a preference from, we're going to try one and we're going to monitor you. And those should be two treatments that have A or B level evidence. Do we kind of narrow some of that decision making down so it's a choice for the patient? There's some preference involved, but we're not making it seem like, this is a big, crapshoot. Because I think it is, when you talk about group effects, I think it's pretty clear when you look at distributions from trials, there's range of responses. And what I would hate is that we somehow are muting, we're bringing everybody to the middle response when,
Sure.
when actually, in order to have really good responders, unfortunately, you have to have really bad responders. Most distributions work out that way. So, I don't know that I directly answered it, but I think the way I would use this information to engage patients is, again, kind of on a broad level. And I probably would use it more for people that would say, well, why aren't you using dry needling? Or why, I would probably use it more for the things, that people get really excited about, maybe prematurely, and kind of saying, well, we're going to give this a try first. Here's the reason why. We're going to monitor your response. If that doesn't work, we'll move on to something else. And that may help someone understand why, you're not using the flavor of the month, and help them have a chance to respond to that treatment.
I guess my question on that is, though, what is the reason why, right? Like, what is needing to be said to patients to do a joint manipulation or to do dry needling? What's the narrative there?
Well, I mean, is it different than the narrative for exercise? I mean, I guess that's where I'm.
Oh, I don't disagree at all. Like, I say the same thing in regards to any intervention you guys looked at.
Yeah. I mean, I think my narrative, and keep in mind, I don't treat patients, so this is my imaginary narrative. But when I did talk to patients, I did treat patients. It's giving them a little of information of what it is, why I think it's appropriate for them. And then, I think what has changed a lot from when I practiced in the 90s to now is you probably feel obligated to say, and this has some evidence behind it through randomized trials. I think in the 90s, that wasn't as big of a deal because, you were more focused on, I think this is good for you, and this is what it is. And, are you interested in this, or can you? And I always, just like in research, part of consent isn't that you give up all your rights, right? And we're going to try this. This is what we're going to try. If it doesn't work out, there are other options we can try. So, making it pretty clear that even by consenting to this one particular treatment, they're not giving up anything other than the fact that we have to start with something. And this is what I think we should start with, or these are two options that I'd like to start with. Do you have a strong preference for one of them?
Do you think we capture very well some of the risks and harms of the narratives that are utilized to validate these interventions? I think you're probably right. Depending on the person, you may get away with just saying, well, this is probably going to help you, so we're going to do it. But I feel like more and more people are inquisitive, and the rationalization of interventions. I think it would be hard to say, well, I'm just going to do a joint manipulation on your lumbar spine without saying, like, well, I think something's moved out of place, or it's going to lose some type of rationalization actually being given.
No, I agree. I think I don't, when I was practicing, was kind of moving out of that mindset of things are out of place and using it more as, we used to talk about it kind of like as a reset, or just, something like that allowed allowed you to have some differing input and maybe perceive things slightly differently. So yeah, regardless of what it is, there is a rationalization. And to me, there's a little bit of a Russian doll with that. Like, some people just want to know that you think this is good. Other people want to know much more. And as a clinician, you just have to be prepared to kind of match that level that the person feels comfortable, that moving forward. And, when I practiced, that doesn't mean, because of the grade A recommendation, it doesn't mean like first decision is manual therapy, yes or no. That's not how every encounter would start. In fact, when I practiced in Western Pennsylvania, we had a fair number of patients that came in that had been treated with chiropractic care for like 3 years. And when you talk to them, they had received spinal manipulation for, like a lot. So I pretty much figured that person, it's like, I don't think a thrust technique is going to help that person, even though, so I think that history part is still so important. And that's why I view these as guidelines.
Yeah, when Chris asked me to do this, the Twitter thread he is talking about, I wasn't going after manual therapy. I think enough people know that that's what Derek and I tend to do anyways. I was going directly after exercise because of the quality level issues with exercise. So I have the same concerns of, like, what are you saying to rationalize exercise interventions to people? Because certainly we shouldn't be saying weak core, loose muscles versus tight muscles, so on and so forth. And so I'm like, it sounds as though the way you view this is you have a bunch of tools in your toolbox that have various levels of evidence, and they should just keep trying until they get that small effect, or am I misunderstanding?
Well, it makes it sound like it's a slot machine. I think there's some attempt to match on the patient's narrative and their physical exam findings and things like that. But I saw what Geronimo put in there. I mean, I think what you're trying to do is pick the intervention that pushes them away from the mean in the right direction. And maybe we're fooling ourselves, deluding ourselves with that, but that's what the patient's hope is, that I'm going to try to stack their odds in a way, that they respond a little bit better than they would have if I had just done, the thing that was most likely to give them the average effect. There's a lot of debate whether that's just delusion, or not. So I think of it similarly, but I do think there is, there's some ordering of the way the treatments are tried. It's not just a slot machine.
What is that ordering? Because looking at, for example, the classification discussion in the CPGs, it also seems very similar to either equality or maybe a couple slightly shining very minimally better than others. But there was even the latest review that said treatment-based classification seems like a wash and there's insufficient evidence. So if it isn't just reaching into the toolbox to get the next intervention until we get a small effect, then how are they applying them?
Well, I think this is where if we all had the same standard approach, I'd be able to answer that better. But I think what you need to do is have an approach that makes sense, that you can communicate and you can apply to others. Again, I'm a little hamstrung in that I haven't practiced clinically, but I trained, when the treatment-based classification system was kind of taking hold. So that still fits into my mind. And, I think of, is this person acting like, they would benefit from manual therapy, or is there some trunk muscle activation, stabilization things that are going on that I'm going to start with? I think what ends up happening, as we know, is there tends to be a grand convergence. Some people end up getting a little bit of everything. I think most people think of front loading with manual therapy and ending with something more active.
Do you think it's possible, or have you looked at potentially our role in perpetuating some of these issues and why we're seeing persistency of low back pain? For example, you mentioned the chiropractor treating the patient for 3 years with the same approach, but then your approach was, well, I'm not going to try that. I'll try something else to get this small effect. Do you think we have a role in kind of perpetuating what we're seeing in persistent pain?
What do you mean? Like, are we a cause of persistent pain, or
I wouldn't say causative, but potential very powerful, important correlate?
Well, I mean, you can't have one without the other in some ways, at least in our healthcare system. So I think it would be a little naive to think that we're not, involved with. I think a lot of that maybe has more to do with providers selling a narrative of, curing pain or solving pain versus, providers that are more willing to say, you're likely to have pain and these are the things you can and should do when it flares up. And here's when you should look at seeking care again. I don't know that many providers, I don't know that we have many of those kind of true management models to help. I think a lot of people still operate with pain as a cure, pain as a curative, and all the data suggests that it's not. So I think, if we are operating in that mindset, then potentially, yeah, because you're just saying the more you seek care, the more likely this is to be fixed. And that's definitely, not my experience with persistent pain.
So instead of eliminating pain, maybe our approach should be self-management. And it seems as though the clinical practice guidelines don't really promote that very much. It seems to be, here are all the things the clinician could do to you. And I understand that a lot of that's the crux of the premise of why you guys were seeking out to do what you did. But if all things are equal and we're looking at small effects, and I can get them to have a small effect by self-managing without me and not thinking they're broken and they need my intervention to fix them, are we just validating our own professions on some level, like attempting to put out, this is what physical therapists do, and this is why you should see one, this is what chiropractors do, this is why you should see one. And some of that being under the guise of, well, this isn't pharmacological management, so therefore it's somehow better.
Well, I think the better of this isn't driven by the size of the effects. The better of this is the relatively lower risk compared to what other options are in healthcare. So, you know, if people are seeing PT or DC continually, and it's preventing them from having, you know, a really costly surgery that's going to have the same small effects, you know, is that who is truly benefiting from that? The profession is, but you could also argue the patient is too. So, you know, I think part of this is, you know, this doesn't happen in a vacuum. This happens in a system that really likes to medicalize things and likes to diagnose things and likes to push people to sometimes invasive, you know, solutions. And we know with chronic pain, that's not the right route for a lot of people. So, you know, if we have this layer of a, you know, like a conveyor belt type of thing, you know, I don't know. I don't know. You know, we're in a very philosophical region here. I don't know. Are we self-vindicating, or are we all actually helping some people from moving on? Because guess where they end up when their surgery fails anyways, right? They end up back on that conveyor belt. So
we have a label for them called failed back surgery syndrome.
Yeah, which I don't use, but you know, I think if you're questioning the existence of that conveyor belt, you know, needing to be there, maybe, but you know, at least there's something that is slowing some things down to the escalation of highly specialized care in an area that we suggest, that most data suggests we don't need highly specialized care, whether it's conservative or medical.
But, and this is somewhat off our current discussion, but prevalence rates would imply that we're not doing a great job with our conveyor belt or any of our options. And some of that may be attributable to population level increases in numbers, but not the amount we've been seeing since the 90s, I would suspect. So, you know what I mean? Like, I don't know that we're actually having net positive effects on folks seeking our care, whether they're DC, MD, DOPT, etc.
Well, I mean, no doubt we're seeing increases in chronic pain, if that's what you're talking about, chronic pain prevalence. And I think it's really hard to tell in this first, I'm saying like in the first wave. There's also been a lot more increase in chronic pain awareness, which in the past. So, you know, I totally know where the trends are going, because we look at, you know, we all look at the same data, but you know, I don't know, you know, what that means, because I think historically there was not this much attention, you know, paid to what pain prevalence was, whether research or routine clinical visits. But you know, time is going to tell. Health systems are on this from a cost savings perspective. So some of this is going to be, you know, some of the systems that are really good at tracking, you know, escalation of care and the costs associated with it and what prevents that. I think some of that is going to be able to be addressed. And we have seen some cases where in a closed system, there is some benefit to having that conveyor belt there, but certainly at a population level, you know, like you're saying, we haven't seen that. That could just be that other systems then are geared to really abuse, you know, the lack of a conveyor belt, if there's incentives to keep things moving along.
I think that's everything I have. I'll leave it over to Chris now. I appreciate you talking to me, Steve, and taking your time today.
No worries. I felt like a dissertation defense. Hopefully I passed. The committee's going to have to go meet now, and I'll probably have to do some remediation. It's not the first time I've had to do remediation.
If you go to CSM, I owe you a beer, so I'll be there.
Okay. Yeah, that'll be good.
Yeah, thanks, Michael, for starting it off. I don't want to put Geronimo on the spot, but I do know he, you know, met with Duke faculty during the y'all's journal club. and had other questions. I don't know if Geronimo wants to chip in, but is there anyone else that has like specific questions or thoughts about the
Sorry, Chris.
CPG?
I do have one other question I
Sure.
forgot about.
Yeah.
If you don't mind, Steve, were there any reviewers who had pretty strong criticisms of this CPG, and were those taken into consideration before publication?
Yeah, I think there was one reviewer who thought we were too soft on two of the recommendations. I don't remember them off the top of my head. It wasn't manual therapy. We did go back and look at those, and we agreed with the reviewer on one of them. So we did adjust a recommendation based on one review. A lot of the reviewers, there was a question about not including, other, but we couldn't redo a search for that one. I think a lot of the reviewers understood where it was and how malleable it was. So it wasn't, there weren't any reviews that suggest it should be rejected, which, is always open when you submit something to peer review. But I think an understanding of the process goes with being invited for a reviewer for this. There were some opportunities for us to clarify our messages and bring up some additional limitations that we took advantage of. So I would say mostly they were tough but fair with an understanding of the process. And I don't even think for this review, I don't know that you even get asked, whether you want to recommend it for publication, because I think the understanding is, it's moving along.
It's getting pushed forward, right?
Yeah. I mean, if it were a hot mess, it maybe would have been stopped, but hopefully we do, like, JOSPT is involved preliminarily, and before it goes out to the external reviewers, the editors are reviewing it and culling it and asking us about our recommendations, and they're looking at the the search and things like that.
Okay, thank you.
Okay, anyone, opening it up to anyone who has questions or thoughts?
How did the first one go today?
What, first, a journal club?
Didn't you have one earlier?
That was
Or-
yesterday.
Oh, that was yesterday.
Yeah. Matt, did you have something?
I was just gonna ask, the 2012 CPG had the intent of the 5-year plan update. Was there anything with this one planned or recommended? Is the
I
goal
think-
still 5 years, or?
Yeah, I admit to not keeping up, but my understanding is this will be updated within 5 years. We're going to meet at CSM with the JOSPT team that does these, or the Academy team that does these, and I think we're going to give our debrief and share some of our opinions, which I'll share with you. This doesn't mean they're going to take them, by the way. I mean, we basically are going to recommend, that they also convene some extra teams to look at the other parts of the guideline that we weren't able to update, whether it's, some of the diagnosis or the measurement, because back pain is such a large literature, that I think you probably want to have a update coming out every 2 years on back pain around something. Whether they agree to that, I don't know, and I don't know if they're super happy that we focused on intervention or not, but a lot of it was based on survival. We wanted to focus on one area and we wanted to do a decent job. So Matt, good question. Hopefully, we'll make some recommendations, and then the Academy will go from there. In the past, they've tried to keep some continuity on the author teams. I've done 2, so I'm done by choice. I don't know that there's term limits or anything, but I've been involved with this enough, and hopefully there's some people that are still interested in then moving up maybe into more of a leadership role, so there'll be some continuity.
And then maybe to go off of that, is there anything that we as clinicians can do to stay on the board in some way to encourage them to try to fulfill those promises of updating maybe every 5 years? Is there
Yeah,
do, or?
and in fairness to the Academy, the inability to update was largely from the author team, of which I was part of, the original author team. So some of it is, you know, if you feel like, if you've, I would encourage you to, you know, give them feedback on whether, you know, this type of grassroots volunteer approach is the way to go for all of their guidelines. I'm not going to disparage any clinical practice guidelines by the Academy, but we had a good chuckle in our group that right after ours was like the hamstring injury guideline. So it's the same kind of task force, same size group is looking at hamstring injury. And I'm not saying anything about hamstring injury other than I'm guessing the size of their literature is like 1/30th of what we had to look at. And I think the Academy, you know, may want to rethink if there's high priority items, of which back pain would be at the top, you know, maybe there's a different way to look at those versus hamstring injury. Does that help, Matt?
Yeah, great. That helps a lot. And I know you guys were limited by this is like a volunteer effort, so that the task you had to overcome is
yeah, and I don't want to use that as an excuse because, you know, we all signed up for it, but you know, I think as you are involved with other groups and you see what's going on, it's not like Julie doesn't know what she's doing. It's not like I don't know what she's doing. It's just, you know, there are restraints to our time, and also restraints to what resources were provided. So we're kind of used to going out and getting those resources on our own through grants and things. Most places, though, you know, other associations fund their practice guidelines.
Steve, do you feel, I mean, there's research that always compares clinicians to the clinical practice guideline and the use of those guidelines within their practice, and whether or not that's kind of now the standard of practice and should be the standard of practice, right? And so we have this with all of its limitations, right? And with some of the I would say angst about, okay, are we going to use needling? Are we going to use some of these other kind of things that are there potentially, right? You may use those, or you may do that, right? Kind of things. Do you feel that this is something that clinicians in the future are going to be confident in being judged against?
I mean, it's a great question. I think you probably are more sensitive to that than I am. You know, I think what people do with the guidelines, from the reimbursement policy, you know, clinical practice part, I think is really interesting. To my knowledge, you know, the guidelines haven't been used quite yet as directly kind of what you're talking about, like that 1-to-1, but they are there to set guardrails. And I think there's some value, you know, to having those guardrails. And for me, like the batting average example, if I were looking at this and someone had 100 patients and they used dry needling on 98, and I looked at the guidelines, that would set up a flare, you know, for me that I need to check this out. If someone is using dry needling on 10 out of the 100, you know, it wouldn't matter at all. So, you know, I would like to think that it's not used to say these are your only options, but it would suggest that there may be some of these treatments that you should be using more frequently than others. And that should correspond a little bit with the recommendations. Does that make sense?
Yeah, I just know that there's literature, there's people producing literature based off of, okay, this group at this percentage, people that have this certification or this kind of thing follow the clinical practice guidelines. And if we're following those guidelines, we're expecting a different outcome than those that aren't following the guidelines. I'm not sure that we can necessarily say that we can change that based off of these clinical guidelines.
Right. And those studies are always interesting to me because I don't know what the upper limit is for following the guidelines. Like no one's going to follow them 100%. So what, you know, what is someone who is guideline adherent? You know, I don't know as a researcher. That's kind of scary. Maybe I shouldn't admit that, but you can edit that part out, Chris. But I don't know, you know, because I think in some ways, someone who's 100% adherent that's a different problem. Is that someone who is,
By thinking.
yeah. So, when I see those, I think they're interesting, but, I always am curious as to what is kind of the sweet spot for that. And
That's
is there
fair.
a sweet
That's
spot?
fair. No, I just, knowing that literature is out there and that people are studying versus what you're doing as far as the clinical practice guideline, it's just kind of one of those things like, is that something in the back of my head as a clinician that's eventually going to
Right.
affect pay and what my standard of practice is supposed to be, right?
Yeah. I mean, it always sounds bad with back pain. Part of them is we have so many guidelines, so you don't know which one. But then when you look at other things like stroke and then it's like, oh, this gives us an idea. It's not like in other areas of medicine, everyone's batting 1,000. The people don't follow stroke guidelines either. People don't follow. So I don't know what that, like I said, I don't know what that means. We actually, for a DPT student, it ended up being too hard for the librarian to do. One of the things we wanted to do is kind of a tie into this one is when we were doing our literature searches, of course, we found all the other low back pain practice guidelines. So we had an idea to maybe look at whether the number of guidelines in an area in stroke and back pain were the ones that we thought we could look at had any relation to guideline adherence or not, meaning do you expect in areas that have more guidelines, is the adherence just automatically lower because there's just more information? In any system that has more information, there's going to be, difficulty in matching that.
How do you think that we control the noise within practice?
I mean, it's a good question. I think that has to be a filter probably at the individual level, because every guideline has its own kind of noise source. We talked a little bit about what our noise source was. So you can't rely on the, even the Academy of Orthopedic Physical Therapy guidelines, there's some noise. So I unfortunately, I think some of that is, at the individual level.
Okay, fair.
Steve, have you seen the JAMA article that came out this year looking at guideline discordant care and how it's a risk factor for the development of persistent low back pain?
I do think I remember that one. It has been a little while.
I was just curious if you had any thoughts on that. It seemed related to the discussion you and
Yeah,
Paul
not informed thoughts, but yeah, that was one that I can look into afterwards a little bit more.
Hey, Steve, not so much a question, just I know with that you're going to be talking to the people that are going to update this, and I don't know if you've seen how Cochrane just did their systematic review for exercise, but basically, obviously, that was a huge undertaking. 270 trials got included, took them whatever 8 years, and basically exactly what you're saying, like, people don't really fund systematic reviews, so it was very hard for Jill Hayden's team or whatever. Anyways, what they're doing now is they're going to be the exercise for low back, essentially like the living systematic review, and you can apply if you have more specific questions to use your data, and so nobody else has to come in and do an exercise for low back pain systematic review all over again. 20,000 whatever initial trials. And so like I've been a part of that, asking some more specific questions using that data, but that's something that I thought that guidelines in general, and I know that's definitely not up to you, could do is, somebody that like NICE, or I know the World Health Organization has just got a team together to do a low back pain guideline as well. I think Jan and Chris are leading that one, but use that, somebody that has that funding for a large guideline, and then for like, let's say APTA, you guys can now go in, ask what's just the PT literature, just like how you did, but instead of having to start from scratch, you can use their already collected data, which is basically what Cochrane and Joe Hayden's group and are doing for systematic reviews. It's something that you might want to.
Yeah, I mean, definitely. Like I said, I hope the next one is a level up in something like that, where there are going to be some data sources available that maybe I can tell you from my past experiences, sometimes there are political issues that people don't want to share, across different things like that. And sometimes that, and I'm not saying that happened in this case, but I'm saying just if the next one doesn't involve that, it doesn't mean that people didn't try to do that. I became very frustrated with the APTA and some things when with the unwillingness to acknowledge that, ISP had already had some, given some really good guidance on pain assessment and things that were driven by PTs, but, they felt there was still a need to do some independent work within the association. So, it's a little soapbox, but I agree. I mean, I think as a researcher, if someone has a resource, a data resource like that, and they're willing to share it, I would be all into that. Anything else?
The only thing I got, Steve, is Derek says, hey, and to tell you that West Virginia sucks.
Yeah. That's the legitimate, the legitimizer from him. Yeah. So
Yeah.
I will tell you, it was a lot easier to deal with Derek in his West Virginia sucks comments before Clemson won all those national titles in football. It used to be quite easy to put him in his place, especially after a certain Orange Bowl that I attended. But since then, I've had to bite my tongue, which I don't enjoy doing around Derek.
I don't know if you know this, but I went to University of South Carolina for 2 degrees. So he and I have fun discussions.
Yeah, I was going to say, I'm surprised he even talks to you.
Oh, yeah.
Well, he grew up in West Virginia. So I used to tease him that the only reason he went to Clemson is because he was like one of 4 people who couldn't get into WVU. So that, that's always good fun. You can always poke fun of him about that.
I play country roads every chance I get when I'm around him.
Well, it's all to hear that after a football game. This year has not been a stellar year for the Mountaineers, but
yeah,
we will persevere. Speaking of being persistent, my own kids who are now applying to college they're like, why did you go to school there if they, they're not? It's like, it's a long story. Just choose wisely. Either go to a school that doesn't, get that much into football, or choose wisely.
Did you burn any couches in your day?
I went in the 90s, so I didn't directly, but there was a lot of couch burning going on. The difference was there was no social media, so people just kind of, it was what you did after you beat Pitt. Miami was a big big rival back then because of the Big East. For those of you who are old enough to remember when Big East had football, so yeah, but they do that on Franklin Street here in Chapel Hill. It really became an issue when the Pittsburgh News used to like to come down and showcase, the heathens down in Morgantown burning couches. And then they would leave out the part that the National Guard had to be called into Happy Valley to the Penn State fans in tow. So, but yeah, those were good times. We were there. Went where?
My wife went to WVU as well.
So yeah, that was one of my favorite T-shirts was WVU, where what greatness is learned and couches are burned. That's one of my favorite T-shirts.
Well, thanks for your time today. I appreciate it. Like I said, I owe you a beer at CSM.
Yeah, well, hopefully this was helpful. And like I said, I appreciate the chance to try to explain a little bit what happens under the hood, and not here to make excuses, just here to explain a little bit. And hopefully the next in 5 years, it'll be really interesting to see what comes out. They're basically going to be having to start that in the next two and a half years. So hopefully they can get a group that is interested to keep this moving along, and we'll make our recommendations at CSM. And then I think some of us are going to sign off, because like I said, two is enough. And there's so many voices in our profession. This is your chance, to be heard.
Perfect. Thanks, Steve and Mike, for doing this. I really appreciate it. it did feel like you were undergoing a PhD dissertation. So I appreciate it.
Yeah, I hope I did all right. Like I said, I look forward to the committee's, responses and what I need to address for the next draft. I've done this before, so yeah, I know what to do.
Awesome. All right. Well, thanks everyone else for joining the party.
Yeah,
Yeah,
congrats to Derek again. That's great news. Thanks for letting me know.
Yeah, I'll pass it on.
All right. Everyone enjoy the rest of your weekend. Bye.
Thank you.